Today I'm going to be talking about leveraging some of the experimental methods that were talked about today to look at cannabis reinforcer pathology, and we're going to do that using smoking photography. So my goal here was to kind of, in line with the experimental assessment of cannabis administration, I wanted to take something that we've confirmed cross-sectionally and pull it into the laboratory to see if we could replicate it. Obligatory cannabis slide. So 38 states and DC legal for medical use, 24 in DC legal for recreational use. The important part here is that flower remains the dominant formulation both in the US and Canada, right? So this typically means using flower in a combustible way. And I'll first start by talking about some behavioral economic domains, and I'm going to tie that into the talk using reinforcer pathology, the theory there. So I'm sure a lot of you know behavioral economics is the combination of psychology and economics, and we use that to study decision making. And that includes decisions regarding cannabis use and cannabis use behaviors. So demand, this is actually relative cannabis valuation, so it's how much you value cannabis relative to something else, like money. And it's really the association between consumption and cost. We typically measure this using a marijuana purchase task, or MPT, and we look at how much cannabis individuals would purchase across escalating levels of price. As price goes up, typically purchase and consumption goes down. Makes sense, right? From those tasks, we can obtain 5 indices of demand. These include intensity, so that's how much cannabis you would use if it was free, use or purchase if it was free. Omax, that is the maximum expenditure that you would allocate for cannabis, so the max that you would pay. Pmax is the price at which Omax happens. And then breakpoint is the price at which your consumption is suppressed to 0. So at that point, you're like, it's too expensive, I'm not going to continue purchasing this. And then elasticity is the rate of decline in your purchasing relative to the increases in cost. Demand has been related to a lot of things when we use it to study cannabis, and these include things like use frequency, whether that's cross-sectionally, retroactively, using EMA, state craving, cannabis use disorder symptoms, problems. I could go on. Another important behavioral economic domain is discounting and delayed rewards. So this is basically looking at people who might wait for rewards. So they value those larger delayed rewards. The rewards are larger, they're able to wait for them. And then we also have smaller immediate rewards, right? So the reward is a lot smaller, but you get it right away. And percent LDR, or percent of larger delayed rewards, is kind of what I'm going to be talking more about today. This is just the proportion of your choices that are for those larger delayed rewards. And then delayed discounting has also been inconsistently related to a lot of different cannabis use behaviors, but these include things like coping motives, cannabis use disorder symptoms, and use. So I want to combine those two things into what we call reinforcer pathology. And this is something that was developed by Bickle and colleagues a couple of decades ago. And it's really the joint effects of these two things, demand and discounting. So it's this persistently high valuation of some kind of commodity or reinforcer. And those are usually like tangible experiences or commodities. And we pair that with this excessive preference for those immediate rewards, right? And for this, we can apply this to cannabis. This reinforcer pathology kind of develops over time, and it results from this recursive interaction between endogenous and exogenous variables. So these typically include, various physiologically mediated subjective responses to cannabis and other substances, devaluation of those rewards that are delayed, and then different kinds of environmental level variables like alternative reinforcement, availability, price, things like that. We have confirmed that reinforcer pathology exists among those who use cannabis across several studies. And typically, we don't see an interaction between demand and discounting, predicting things like use or problems, but we see them separately predicting use and problems. Typically, it's some kind of demand indice that's predicting use, and then some kind of delay discounting variable that's predicting like problems or CUD symptoms.
Well,
all right, I want to bring all of this together and tie back to what I was saying earlier, that I wanted to take something that was assessed cross-sectionally, confirmed cross-sectionally, pull that into the laboratory. So I wanted to do this using something topography. And this is similar data to what Ben presented earlier. We can use something called a crest pocket or different kinds of topography devices, right? And these characterize the way in which someone smokes, their topography. A lot of different variables can be obtained, like your number of puffs, how long you spend smoking, your puff volume, and then the time between your puffs or inter-puff interval, among other variables. But that's what I'll be focusing on today. We've looked at topography and tobacco a lot, right? So there's a lot of research on that in the literature. As far as I could tell, there still remains only one demand and topography study in the tobacco literature. And they found, various things having to do with the indices. So intensity, that's, how much you would use if it were free. That's negatively correlated with inter-puff interval. And then OMAX, that's that maximum expenditure that you would allocate to cannabis. That's positively correlated with the number of puffs that you're taking. We have limited work still, so some studies, but limited work looking at how individuals smoke cannabis within a session or an event, right? So some work has shown that your puff duration and volume decline over the course of a session. That makes sense, probably because at the beginning of a session, someone's trying to titrate up their, response there, and then over time, they kind of do it more slowly because they're trying to keep that level that they desire. We also see that puff volume and duration have been associated with the number of cannabis use sessions that you might engage in outside of the laboratory.
Yep.
And as I said, things going on here probably relate to titrating to this like THC, intake amount that may be preferred for an individual. And then there's likely a role of tolerance here too, right? So I'm sure that plays a role. But there is limited work on this so far. And just as we see with tobacco and some behavioral economic indices like demand and reinforcer pathology and things like that may predict topography indices similar to what we see with tobacco. And that brings us to our current study. So the study aim here, as I said, was to extend that reinforcer pathology framework or theory to the laboratory. So what I wanted to do first was confirm that it existed in this sample at baseline and then bring it into the laboratory. And as I said, usually we use some measure of problems or CUD symptoms as the outcome, and we also use some measure of frequency as the outcome. Here, I thought to conceptualize those indices of puff topography as the frequency or use measure there. So at baseline, people came in, they filled out the marijuana purchase task. I used the HITS version here, so we have several different versions, right? HITS is not my favorite, but I used it here because that's kind of what we're doing in the laboratory. They're taking hits off of this device, so it seemed the most appropriate version. We also used the monetary choice questionnaire as an assessment of delay discounting. They underwent a structured clinical interview to assess for CUD symptoms, and then we took typical grams per session from the DFAQ CU. Individuals returned for an ad libitum cannabis smoking session that Ben talked about earlier. So they first completed the state version of the marijuana purchase task. So that was basically how many hits would you purchase right now at these escalating levels of price. Then they were permitted to smoke up to 2 cannabis cigarettes over an hour using this Crest Pocket device. Again, the potency was 5.9% THC. Each cigarette was about 0.7 grams. And then afterward, they filled out a marijuana rating form, just kind of telling us all kinds of things about if they liked the cannabis and things like that. Our inclusion criteria were that individuals had to be 18 to 50 years of age. They did have to endorse cannabis use at least twice a week in the past month, but we confirmed that with the positive THC test. They also had to report cannabis purchasing just because of the behavioral economic indices that we were really interested in looking at. And then the negative pregnancy tests, no past adverse cannabis reaction, and they couldn't have a medical registration card. So we did have nearly 40% of our sample was female and or of minoritized status. and about 30% of the sample were considered to be having like severe CUD symptoms, so 6 or more symptoms. And then at the bottom here, I have those behavioral economic demand indices, both the trait version that was done at baseline and then the state version that was done before they smoked in the laboratory. There's actually some interesting things going on here. So if you look at intensity, when we just ask them on a typical day, how many hits do you want to take if they're free? They say about 24 hits. There's a lot of variability there. But in the laboratory, when we ask them right now, how many do you want to take if they're free? That's about 18. So it's definitely less. However, they're willing to spend a less maximum amount outside of the lab as they are inside of the lab. So about $12 maximum outside the lab and then $16 inside the lab. So those are interesting things that will kind of play a role later in the talk. Okay, so then we conducted a series of multiple regressions, a couple of them just showing that reinforcer pathology does exist at baseline. That's our first model. So our sample size was 61. This was unfortunately interrupted by COVID just because we had to go in and out of the room. So we had to stop recruitment for that particular aim of the study. And for all of these models that I'm going to show, I first did the analysis with all of the demand indices, and then I trimmed it for parsimony afterwards. So any demand index that was a p-value of less than 0.1 was retained in a subsequent model, and that's what I'll be showing. And then we always conducted the delay discounting model. In these first two models we're looking at this cross-sectionally, age and biological sex were covariates. So here, when we are predicting typical grams smoked per session, we see that demand significantly predicts that, specifically breakpoint here. There's a trend for Pmax as well. And then delay discounting did not predict this. This is just as we would see in the literature. So demand predicts each. Then we were predicting cannabis use disorder symptoms. So here, demand was not significant. So you can see the full model here. But delay discounting, specifically LDR, was significantly predictive of cannabis use disorder symptom count. Great, right? So we've confirmed reinforcer pathology in the cross-sectional data here with our sample. Now I want to go to the ad libitum section. So I'll have 4 models here. First, we're predicting number of puffs. And here we see that in the laboratory, that demand analysis, or the demand measure that we did right before smoking, Omax, breakpoint, and elasticity all significantly predict the number of puffs that they take during that session. Something interesting that I will touch on later is that the direction of a couple of these indices is not what we would typically expect, and I have some thoughts about why that might be. We did not see any effects here for delay discounting. We also included a visual analog scale of I liked it related to the cannabis that they smoked that day. This is kind of important to include because anyone who does work with the cannabis from the United Drug Supply Program knows that it's not that similar to what they use in real life. So we wanted to make sure that we covariated for that. Next, we're predicting total smoking duration across the session. So here we did not see significant effects of either delay discounting or any of the demand variables. Next, we're predicting puff volume. So here we see that both breakpoint and elasticity predict total puff volume over the session, nothing for delay discounting again. Finally, we're predicting inter-puff interval. And here we also see that nothing for demand and nothing for delay discounting is significant. So 2 out of the 4, we did see significant effects. And just to summarize that, we did replicate reinforcer pathology at baseline in the sample. It made sense. Demand predicts a use variable. Delay discounting predicts a problems variable. We extended it to the laboratory partially. So demand predicted some topography measures. Delay discounting did not predict any of them. So I do think that topography can definitely be conceptualized as like a frequency variable. And that may be why we didn't see effects for delay discounting, right? Because typically that would predict CUD symptoms or problems. Some key considerations here. So again, we saw that these 3 demand indices, Omax, breakpoint, and elasticity, significantly predicted puff term. And then breakpoint and elasticity predicted total puff volume. Counterintuitive direction for breakpoint and Omax. So as Omax went up, so that's that maximum expenditure, the number of puffs went down. That's not really what you typically expect. And then same for breakpoint. As breakpoint went up, so you're willing to pay more per unit, your puff volume went down. And you might have expected the opposite to happen. First, it's not typical to put all of the indices in the same model, but we had to here because of our sample size. So, because of that, we don't really know what happens in the literature when we have all of these variables playing together. We did look at, whether there was collinearity, and there wasn't, but we still don't totally have enough data to assess this. And then it's possible that maybe those with higher breakpoint, so they're willing to pay more per unit, they're taking fewer or smaller puffs because they're sated more quickly. It's definitely a possibility. And then for Omax, they may be willing to spend more for less because it's not taking them, like certain participants, as much to get sated. Those are possibilities, and I spent a long time with my collaborators discussing what's going on here. We'll continue that before we publish. And then in terms of delay discounting, if we had cannabis as the commodity instead of money, that really may be a better way to look at this. Delay discounting is less than consistent when you use cannabis as the commodity versus money as the commodity. So building off of what Ben said earlier, topography may be a really great thing to manipulate in terms of intervention to try to facilitate the cessation or reduction in use. Cannabinoid composition, mode, and formulation definitely all play a role in this. And whether or not they like the cannabis plays a huge role in this as well. And then measuring this in naturalistic settings, as almost all of my co-presenters have noted, is really going to be important in the future, especially as these novel formulations continue to proliferate. And with that, I will end. I would like to thank all of my collaborators on this project and my funding from NIDA